Hi, everybody. Welcome to the DRC's focus area session on evacuation on this wonderful September 2nd, day after a holiday. Hope you enjoyed your weekend. So we are going to talk today about promoting psychological safety and behavioral mental health for staff during an evacuation. So we have great speakers for you today. Hopefully you get a lot out of it. We're going to have time for a breakout session at the end so we can talk about what's going on in our own hospitals. So thank you for joining us. Before we get started, I want to make sure to let you know the Pediatric Pandemic Network is supported in part by the Health Resources and Services Administration of the U.S. Department of Health and Human Services. The content presented today is that of the authors and does not necessarily represent the official views of, nor an endorsement by HRSA, HHS, or the U.S. government. We will be offering continuing education units and continuing medical education units. You'll see at the very bottom of the screen the requirements to claim those CE credits. You must attend the entire session. You want to ensure the complete session evaluation, which will be offered at the end of today's session. And if you have registered for the session, we've got your name and we've got your attendance. If you're using somebody else's registration, if they forwarded that, make sure that you rename yourself on your little Hollywood square. And then the instructions to actually go in and claim that CE credit will be at the end of the slide session today. So again, we are very pleased to have you with us. We know today is a busy day coming back. We will be recording this session, so the recording and the slides will be up on our website later this week or early next week. If you have any questions for the speakers or in general, please feel free to put those in the chat or the Q&A feature. Chat is probably going to be better. I will say that. I think we've all been using the chat for the most part for questions. And then at the very last, wanted to just keep update with all the DRC priorities and things that kind of your checklist. So the TTX data collection survey, I've had a couple of questions that maybe your after action report took a little while to complete after your TTX. That is totally fine to go ahead and continuously update that or complete that data collection survey. That is for you and for us to identify gaps and strengths. So we'll be happy to go ahead and take that data. The PDPAC also, that self-assessment, the large self-assessment, even though we've closed it, like a light close, if you are still completing maybe a section or a last minute couple of pieces of that, feel free to go ahead and complete that and submit that. We will take that as well. And hopefully you have started planning your hospital's drill. So we're maybe sometime now until the end of the year, maybe think about who needs to be there and starting to get that scheduled so that that can be on their calendars. So as you start to plan the little logistics and the details, at least you've got the people that need to be there and that on the calendar. This is our agenda today. We're going to move around a little bit, but we'll hear from Dr. Schreiber, and we'll also hear from Brian Barth and his team at Children's Hospital of Philadelphia. Here are the objectives. We're going to get some actionable strategies for hospital leadership can contribute to the well-being and resilience of staff. We want to prepare for psychological safety of staff during an evacuation event. And we want to identify how to integrate behavioral health staff into your evacuation plan. So actually incorporating that staff. I always like to look at what we did last month, so last month we had the full collaborative session. So back in July, we talked about staff engagement and the evacuation of equipment, and how that works together. We talked about staffing concerns and how to get the staff involved. And then we also talked about creating a readiness culture of everyday readiness and what little things that we can do to keep going and to prepare our staff. So today we're going to talk about planning for evacuation and some staffing considerations, and then being prepared for the staff psychologically, and making sure that we're taking care of our staff. Before we get into this, I want to give a disclaimer. We have to take care of ourselves. As hospital employees, there is a lot going on in the world right now. The information in this session is heavy. So keep that in mind, that we want to take care of ourselves as individuals, but also being kind to one another. So while on this session, if you need to turn off your camera, if you need to step away at any time, please feel free to do so. Okay? And with that, I will hand it over to the team from Children's Hospital of Philadelphia. Thank you, everybody.
Great. Thanks, Julie. My name is Brian Barth. I'm the manager of emergency preparedness at Children's Hospital of Philadelphia. I've got a few team members with me today. I've got Dr. Regina Toto, who is an ED physician and also the medical director for the emergency preparedness program here at CHOP, and Austin Cassidy. Austin is on our team as an emergency preparedness and safety specialist, primarily working in our behavioral health environments. We're going to touch a little bit on some general evacuation considerations in a behavioral health environment, as well as how we can draw upon that program or those programs for staff and or patients and their mental health needs during an actual evacuation event. Next slide. And we're going to start by mentioning our Behavioral Health and Crisis Center in Philadelphia. This is really a new venture for us over the past year and a half. Up until that point, we only had a 10-bed inpatient medical behavioral health unit at our main campus and a small adolescent unit as well, but not really a behavioral health facility per se, which we now have with the Behavioral Health and Crisis Center at Cedar Avenue. It does have a 24/7 walk-in pediatric crisis response center. It's got a total of 46 inpatient behavioral health beds across 3 different inpatient units on 2 separate floors. And it is a little different situation. It is a hospital within a hospital. Some folks are familiar with that setup, but it's a hospital within a public health campus. So 3 totally different entities coming together to make this campus work. It's our facilities with the crisis center on the ground floor, one of the behavioral health units on the 7th floor, and in between the other behavioral health units on the 4th floor of the building, and the other hospital who's also a tenant in that location, the University of the University of Pennsylvania, makes this a unique situation. Next slide. I'm going to turn it over to Austin for a moment just to talk about that uniqueness and some of the planning and response efforts for this particular site.
Thanks, Brian. So as Brian mentioned, we are a hospital within a public health campus. You know, when we moved in a year and a half ago, it was already an existing adult hospital. So we rely on the hospital of the University of Pennsylvania for our facilities management, some security needs. So it's really important that we collaborate with them in response to all emergencies. They have adult inpatient units, they have a hospice unit, as well as an emergency department. They also have a crisis center for adults and an inpatient psychiatric unit. So like I said, it's really important that we work with them. Obviously, we work with them on day-to-day stuff, but when we're planning and when we're conducting exercises and stuff, it's integral that they're included in those preparations. And then our other partner that Brian mentioned is the Public Health Management Corporation. We work with them to a little bit of a lesser extent. They actually own the campus, own the building, and they have oversight over all campus operations. And then they actually also have a few clinics of their own that they run in there. You can go to the next slide, Julie. This is just a quick snapshot of our staffing model. So we have 6 patients for every 1 registered nurse on our inpatient units, 4 patients for every 1 psychiatric technician. Brian mentioned we have 46 total inpatient beds. So, if we're at full census, we likely would have 8 nurses and 12 psychiatric technicians to assist with an evacuation if we needed to do a full facility evacuation. Our crisis center, we have 1 nurse at all times. As Brian mentioned, it's 24/7, that crisis center. We have 2 psychiatric technicians and then 2 mental health evaluators. Other roles, we have 4 of our own security officers, 3 patient service representatives who are both 24/7 roles. And then we have a number of creative arts therapists, providers, psychiatrists, etc. Obviously, if we had to evacuate during the day, we would be in a much better position because a lot of those therapists and providers are only working day shift 8 to 4 or so. So you could go to the next slide, Julie. And I'm going to kick it back over to Brian to handle this slide.
Thanks, Austin. Yeah, as Austin mentioned, the staffing is limited at the site. We make every effort and most of our planning to try to manage the situation with either sheltering in place or with a partial evacuation, whether it's a horizontal move from one smoke compartment to another, or vertically from one unit to another, or even potentially into the space of our partners at HUP. They're on the same campus, with the last effort being a full evacuation, particularly because of the patient population and the limited resources across the region to be able to support that patient population. But the building is a building that was built in 1918. So the potential is always there. When we look at facility evacuation, some things are standard. Some things we utilize in both settings. From an incident management perspective, we utilize HICS, the Hospital Incident Command System. We have folks who will be on-site roles versus enterprise roles, with a number of folks that will be involved in patient movement activities on site. Will be supplementing with folks from other campuses. Some of the specific roles that we utilize we have an on-site 24/7 clinical supervisor who is the lead of operations for an evacuation. Each unit charge nurse is responsible for coordinating evacuation triage, the resource needs of the unit to move patients and patient flow. We have the provider that's there for the inpatient units as well as for the crisis center. They act as the behavioral health subject matter expert for this site. They also serve as a behavioral health subject matter expert for an overall evacuation, whether it's at this site or another one of our locations. And then staging operations, personnel needs, equipment and supplies, pharmacy, vehicle transport. A lot of these roles with an asterisk here, we count on additional offsite support from our other locations to supplement the few folks that we have on site with patient tracking, staff tracking. We utilize Javari and EM Track to track individuals moving from one site to another should we need to do that, and also work on discharge and transfer coordination through that system. From a mental health perspective for our staff, we also, during a response have a few subject matter experts in addition to our providers. We have an Office of Employee Wellbeing and a Care for Colleagues program. Both of those programs are available. They really came about through the COVID response, and we count on them on a number of occasions, and certainly would count on them for an evacuation event where we may need to get additional support. I'm going to turn it back over to Austin. If you want to go to the next slide, Julie, and just talk real quickly about a couple of the more specific behavioral health needs for facility evacuation.
Thanks, Brian. So as Brian mentioned earlier, we do have some limited staffing. That's where our building partners come into play. We'll definitely need some increased security needs if it's a full facility evacuation. And that's where we count on our hub partners to, assist us with potentially some extra security support. Some special conditions we've talked about is minimizing stimulation for patients. Obviously, in the event of an evacuation, patients are at an increased risk for escalation. Monitoring of patients at risk for elopement during transit and also in the holding and staging area. That's where we're really going to need that increased security presence, especially in the holding and staging area for patients that are identified at an increased risk for that elopement. We've talked about our process to manage patients that are in seclusion or restraint, needing to put in those restraint orders, put in new orders once the evacuation is complete, new face-to-face evaluations with the psychiatrist, alternatives for patient movement, alternatives for ambulance transfer. Nothing's set in stone, but we have discussed potentially using a shuttle bus to transport multiple patients at once if we're sending them to the same facility, rather than having 46 ambulance, come through the hospital to move out all 46 of our patients. Our clinical leaders have estimated that somewhere between 10 and 20% of our inpatient population would be safe for discharge at any given time. So some other considerations with that is just making sure we're doing safety planning with the patients and their caregivers if they are being discharged home. And then some considerations if we are taking them to another facility is how long it's going to take for them to be accepted, and what kind of bed availability we have in the other pediatric psychiatric units throughout the region. And we've talked about emergency department transfer versus medical inpatient transfer, just as a temporary measure until those beds do open up or until those other facilities are ready to accept our patients. You can go to the next slide. I'll real quickly just discuss a couple pieces of evacuation equipment we have on site. So we have the med sled by Ethos, and then we also have the stair chair by Stryker. We have one of these on each of our inpatient units. They can be used for horizontal and vertical moves. We train our staff on these. We try to train each staff member, at least on our nursing team and our psychiatric tech team, once a year. Some feedback we received is that they may forget about how to use these pieces of equipment 8 months after a given training. So we're working now on having some sort of a just-in-time training available in the event of an evacuation. So whether that's a QR code right on the cover of these pieces of equipment that staff can quickly take out their phone and watch a quick video on how to operate the pieces of equipment. But that is still in the works. You can go to the next slide, Julie. I'm going to kick it back over to Brian.
Thanks, Austin. And just wrapping things up, I know it was a little bit of whirlwind on things there, but really our main focus are on those things that with a behavioral health pediatric environment, what can we do to make this work better? From reducing stimulation for patients, what do we do with patients that could be potentially in seclusion or restraint? Very rare that it happens, but it could. Those that are risk for elopement, and someone brought up in the chat that piece of safe to discharge. Some of these patients are voluntary. The majority are voluntary. Some are court ordered to be there. and working through those particulars. But this is just a list of a number of the organizations that we continue to work with to collaborate and improve our potential response. Some of those alternatives to potential transfer, transfer by other means, working on refining some of the roles and responsibilities of individuals on site, and sharing our capabilities versus our needs with our local jurisdictions and partners.
I have a few questions in the chat. Do you use EM track on a regular basis, or just evac and emergency movement is needed?
So we're using it more. It had been primarily for evacuation or for large public events. Philadelphia Fire Department and EMS have started utilizing EM track with us and our other hospitals to track incoming patients to hospitals. So we're getting more familiar with EM track, the ability to use it that way. So it's becoming more familiar with folks, and try to take advantage of opportunities when they arise to get folks more familiar with it.
So this next question, I'm not going to put you on the spot. What I'm going to say is, if you have a written evac plan that you would be willing to share, if you want to send it to me at dncppn. I'm going to put it in the chat. dncppn@austin.utexas.edu. You can send it to me and we can get it out to the group. So I won't put you on the spot there. Thank you.
Sounds great. Thanks, everybody.
Thank you. Okay, so I'll hand it over to Dr. Chip Schreiber.
Okay, can you hear me okay?
Yes.
Okay, thanks. Can you advance that one? So in addition to the disclaimer from that Julie presented, some of the tools and strategies that we talk about, I own the intellectual property and I receive funding from federal, state, and local nonprofit agencies, including the RAPM Pediatric Disaster Center of Excellence and our own Pediatric Pandemic Network. Thanks. Next. So top left slide, I was just a community child psychologist, practicing in a little beach town in Southern California. And then we had a big wildfire in the late 90s. And I got very involved in disaster response, first for the kids and the families. We had about 6,000 kids that were evacuated, no notice, some of them running down those hills, actually toward the ocean, similar to the LA County fire. And I became very involved in disaster, and I was a uniformed public health service officer for 13 years, worked at the Department of Defense on strategies, first for kids and adult disaster victims, but increasingly we had questions about the impact on staff. So kind of my two primary areas of interest and focus are impact of disasters, especially large MCI and surge events on kids and also on those that take care of them. So I went to Children's Hospital for the Boston Marathon bombing. I trained the U.S. Ebola team specifically on mental health strategies for themselves and advised the Surgeon General's office while those teams were deployed for about 6 months. Anyway, so although I work in an academic environment, I have a fair amount of direct experience in real world events. So hopefully the content and the slides make sense within real world events. Next. Yeah, we went to the Maui wildfire. Very impactful, not just on the kids and the families, but on those that took care of them, and including the behavioral health folks. Sometimes we are the absolute worst in terms of responders to take care of our own needs. So next, please. So I think the way to do this, my way of thinking, is a bit more complicated and it involves more steps than maybe is easy to do. And it may be a bridge too far for facilities, but I have to start at least what I think is, optimal. And that is talking about staff mental health before these events happen, and then integrating staff behavioral health into the overall strategy you have for mental health operating in your facility. So we have a children's disaster mental health ConOps that we designed for SAMHSA. It's for use in a variety of different settings. Um, and that's available on the RAPA website. You can Google it. It's on Asper. We've been modifying that specifically for PICU, and we're talking to Annette about, gee, what would we have to do to adapt that for burn unit, pediatric patients on burn units in particular. And we think that the mental health planning needs to, be in accord with the rest of the preparedness model. So pre-event or preparedness, response, and recovery. So, be prepared and expect resilience, but that's not the only outcome. And each one of those phases, I think, really requires some tactical and operational mental health actions that are customized to the way your facility operates. Next. So, what's the pre-existing burden? And that really is a way of understanding what the impact is on your staff on an everyday basis. We already know that nurses in particular are at increased risk for post-traumatic stress disorder and depression, and unfortunately, even suicide rates are elevated. So, particularly facilities that are seeing, a tremendous amount of trauma on an everyday basis. So, level 1, level 2, level 3 trauma centers, pediatric trauma centers, burn centers. What's the history? Have you responded to active shooters and bombing situations? What's the burden of community violence? This is a way to try to get an index to what we call secondary traumatic stress. What are staff already dealing with before whatever the event is that leads to the evacuation? So how is it being handled? Is there a plan? Are you going to give them a little brochure and say, have a nice day? Are you doing CISM, critical incident stress management, which tends to be, in practice, unfortunately, a one-shot approach? Or are there larger organizational efforts? In one of the facilities where I am at UCLA Medical Center, we have Wellness Wednesday. It started during COVID. I'm not sure it's impactful at this point. We've heard people say, we need more than muffins. We need more than just, a table set up on Wednesday with muffins. And I'm not saying that's the totality of what that is. What are the impacts of evacuation? And that is, what's the preparedness? What does staff know about what's going to happen in an evacuation? What's the C-suite? Is there a medical operations center in your facility or in your community that's guiding the larger effort? What are the specific incident evacuation risk factors? And we have a new system I'm proud to share that was just built at the end of last project year for the Pediatric Pandemic Network. And it's called SciStart Responder. And it has a corresponding resilience endurance training called Anticipate, Plan, Deter. I'll try to show you just a smidgen of that. And we're anticipating that will be launched in a learning collaborative type model, similar to the DRC, hopefully, our kind of role models. And that'll be available to across the PPN. So what happens in evacuation? What's the level of threat to staff? What happens to patient care? When pediatric providers can't deliver care the way they are used to, and that's potentially what happens, hopefully not in a disaster, but it could, that is very, very impactful for those that take care of kids. And if the evacuation leads to unavoidable changes in levels of care or crisis standards of care, that is what I'm talking about. And when we talk about preparedness, I wanted to share that my daughter is a new attending pediatrician in a large healthcare system. She's been out of residency 3 years. She's primarily a Gen Peds in an outpatient FQHC that the health system owns, but she attends the nursery well baby nursery that's next to a NICU in this hospital. Sometimes she's caring for 20 newborns on a, daily basis. She's rounding on 20 babies, together with one or two residents. And I've asked her a couple of times, and in preparation for this uh, presentation today, I said, "Hey, do you know what the evacuation plan is for that nursery that's got, frequently up to 20 babies?" And honestly, she doesn't know. She said she's going to rely on nursing. She anticipates that the nurse manager or the surge or the shift manager will know what the plan is, but she herself is not really well versed and not really been trained. And so that's a question, is that an issue that you have an attending physician on a nursery in a relatively large hospital? It's not a children's hospital, but has various pediatric specialty care units, and it's a level 2 peds trauma center. So some of those kids are admitted, the traumas are admitted, and it's also a burn center, a regional burn facility. So is that a concern? And so what happens to my daughter if there's a very rapid evacuation, an earthquake? We live near an earthquake fault line. We have a number of other kinds of hazards, intentional and unintentional threats. So what would happen to her if she's there that day and she has to be the attending when they're evacuating the nursery? And I would suggest the fact that she doesn't know exactly what the plan is, that's an avoidable stress burden, let alone on on the babies. Next. So it's really important as another piece of preparedness to try to have some metrics. Understand what's the baseline level of burnout or secondary traumatic stress? What are the levels of PTSD and depression among your staff? How do you go about trying to determine that? It's really hard to plan for additional burden if you don't have some sense of what's already going on. What systems do you already have in place to support staff? Is it your EAP? Are you lucky enough to have in-house mental health or spiritual care chaplaincy? Do you have community partners that you rely on when there's impacts on staff? How will that be managed? And more generally, what are the mental health systems that are in place for patients, families, uh, and their families? Okay, next. So that there's the colors didn't quite line up there. I don't know. Can you click that again? Let's see if all the circles show up. Nope. Okay, let's go back. So on the left there where it says 50 to 90, there should be a larger green bubble or green circle. So basically, if you're going to plan for the impact on staff, you have to go beyond one size fits all. There's going to be a lot of transitory distress, things like insomnia or fears. Kind of mimics post-traumatic stress disorder, but the good news is that it's extremely time limited, doesn't require necessarily any professional intervention, and the severity is such that it doesn't really cause interference with your ability to function. That's kind of the good news. But we also know that there is already a significant mental health burden among, EM, pre-hospital and hospital-based providers, especially nurses, physicians, fare a bit better. And that rate is somewhere around 20 to 40%. And then you add the additional potential impact of an evacuation, which is going to be in the context of some sort of community emergency or hospital-based emergency. And then you're looking at rates, baseline between 20 and 40%. And unfortunately, when you kind of cross over from the green to the red, that is more than one disorder. It's what we call transdiagnostic risk. So it's usually post-traumatic stress disorder plus something else like depression or prolonged grief disorder. And then again, if there's already things going on, there's already been impacts on staff, that makes things worse. So next slide, please. Basically, it boils down to two pathways that impact staff. One is resilience. That's really the good news, and it's around in the 30% range. The other not so good news is that kind of red risk pathway, which on this study they called chronic dysfunction. But that's, you develop some sort of new or worsening of a chronic mental health condition like PTSD or depression. Those are the two most common, and it doesn't go away without intervention. Next. And there's lots of data out there. Again, this is pre-COVID, and COVID certainly took an already troubling um, landscape of mental health impacts on pre-hospital and hospital-based providers and made things worse. But you can see that on the pre-hospital side and the hospital side, rates, what they're calling PTSD screening positive on a validated measure, are very high, in the 30% range for, ED nurses, ICU nurses. Attendings do significantly better, but residents not so much. And flight paramedics, who are seeing, the most acute patients, perhaps among the highest level of risk on the pre-hospital side. Next. Even the kids, this is a study from police, fire, and EMS responders to 9/11. And basically, what it shows is that the school-age kids of the EMTs had PTSD rates significantly above expectation. They're higher than baseline for those kids of first responder EMTs that didn't respond to the World Trade Center, but if they responded, the rate in the kids was above 25%. That's pretty significant, and much higher than for non-medical responding firefighters or law enforcement. Next, please. Data on surgical residents. Again, this is from the Pulse nightclub, a no-notice event, not evacuation, but showing potentially what the impact of, no-notice mass casualty events is. This is basically showing PTSD rates in the 30% range. Next. And this just was recently published. The link is right there, but basically showing what's the actual suicide risk in healthcare workers compared with non-healthcare workers. And you can see it's, it's RNs, health technicians, and some healthcare support workers, the way they defined it in the study in the United States, were all at increased risk. So throw evacuation on top of that. That's not evacuation related impact. That's kind of baseline, if you will. Next. And there's a big effort at the American Hospital Association, a lot of different places, looking at what some of those drivers are. So, here's some of the pragmatics: trying to destigmatize help seeking and make services available, and mitigating wherever you can the impact of this. So, if you take my daughter as an example, making sure she understands her role in a short notice evacuation might reduce, potential job related stressor should her hospital have to evacuate in the nursery. Next. So it's understanding, what does disaster mean to you? What's a typical bad day? Next. And what happens if it's something like this? What's that going to do to you and your team? Next. This is a wildfire here in California leading to rapid evacuation of a hospital. You can kind of see the smoke basically encroaching on the facility. Next. Little images of what it looks like. Potential for chaos, especially if folks don't know their roles. Next. And apparently at Chalk, the gift shop had to be turned into a triage station. I wasn't aware of that during the RSV triple demic, not that long ago, and we're concerned about what this fall looks like. Next. Yeah, so hopefully you get a sense. We're definitely worried about the fire scenario here. Next. And I would tell you that the evacuation zone for the Palisades fire came within a block of UCLA Medical Center, which would have triggered evacuation. Next. I think I covered all that. I'll try to save some time. Next. Yeah, the rates are in the 20 to 30% range. The good news is we had certain interventions. It's not CISM, it's not all um, psychological interventions, but there are some that are extremely effective in reducing PTSD, depression, and anxiety in responders. They're increasingly available. Some of them are available via telehealth. Some of them are digital delivered. Next. And this is what we're launching for PPN this year. So I'll give you my email, but if you're interested in learning more about this learning collaborative that will be starting uh, probably we'll do intro sessions in December and then launch in January of 2026. But this is, one approach. It's not certainly not the only to develop a comprehensive strategy to build coping skills. And stress inoculation is kind of technically what the model is. We've been doing this in LA and other parts of California for a while. Next. Okay. So basically, it's getting folks to think through what the particular challenges they face in their job role, in their hospital, in the context of what their community faces as potential disasters and then disasters that might require evacuation, hasty evacuation. Next point there. We call those risk precursors. So everybody plans out their own map of what their particular challenges are, and those are actually evidence-based risk factors. And then how are they going to manage the stress of their role in a potential evacuation? Thinking through that now, in the calm light of day versus, in the middle of evacuation. Next point there, the cope. Deter. Okay. Yeah. So the deter is being able to both monitor what their own impacts are and then to trigger their plan and to look at some of the next steps resources that they have available to them in their setting. Okay. Next. Yeah. It gives them automated feedback. It's completely confidential. They can opt out, they can opt in. But if they wish, it'll give them an opportunity to get their baseline of impact. And then if a large event happens, they'll be able to see that difference. And then, they're the enablers of their own plan. But armed with that information, many of them will then take appropriate steps to improve their own resilience. Next. Next. We'll kind of move through some of this. The other thing it does is it'll aggregate without any identifiers. So it will tell folks in the emergency management role at that hospital or even in the larger community, what's the impact at this facility or other hospitals or the entire community, so we can target resources so we know what we're dealing with. Just like you wouldn't attempt to do medical response without triage, so too the mental health component benefits from the same kind of idea and understanding what the burden is at the site and in the community at large. Next. Yep, next. Next. So this is that wildfire I showed you. This one home survived. How was that possible? Was that just the fluke of the winds, or there happened to be a fire resource located there? Next. No, it was deliberative planning. So this house was built differently from the essentially on the preparedness side. They knew what the threat was in that environment, in those hills and in Southern California, and they built the house accordingly. And therefore, it did not emerge without any impact, but largely unscathed. And the time to recovery, which is another way of thinking about or defining resilience, was much shorter than obviously everybody else in that neighborhood. They were able to resume their lives and live in their home in a much shorter period due to deliberative planning on the front end. Next. This is from the National Academy of Medicine. This is another way of looking at issues related to burnout. Burnout's not the same as PTSD, but it is a component, and left untreated, there's a linkage between burnout and depression and probably PTSD also. And these are some of the interface points. So our approach is to look at workload, especially in a disaster, what happens, to look at moral distress. Some people call it moral injury, having to make decisions about allocation of limited resources, crisis standards of care, unfortunately, potential that occurs. Certain kinds of patient factors. We know dealing with kids, especially kids that don't have a positive outcome, is very impactful. And what's the nature of the level of support in that particular healthcare system? Is there a perceived level of support from the C-suite and from supervisory staff? Is there a good existing camaraderie there? But we know kind of across the United States that burnout levels are in the 35 to 54% rate. Medical students and residents, and as faculty in a medical school and working with students and residents, definitely an issue I'm aware of. 45 to 60%, according to the National Academy of Medicine, have that. So their focus is a little different at the NAM. It's on work system factors and administrative burden, and it's on the main variable they look at as burnout and well-being. Our focus, unfortunately, is on the more severe mental health impacts, PTSD and depression, but they are all part of the same continuum approach. Next. This is our mental health concept of operations. Next. We do have some strategies. We just actually, working with Annette here today and others on the Pediatric Centers of Excellence side, some strategies, that we can reduce to basic flow charts, if you will, related to this one in particular is RSV surge, not evacuation, but the same sort of continuum of staff risk and resilience approach. And we're happy to share those with folks. Next. I think you heard the other speakers talk about Hicks. So we worked with LA County EMS, and the goal was to modify an existing Hicks job action sheet that's called Employee Health and Wellbeing Unit Leader, and basically giving them these tools to facilitate the plan they already had, the job action sheet, but we didn't modify it significantly. We just created a linkage with some of the tools we've developed that operationalize some of the things in the job action sheet that aren't very well specified. And this is kind of LA centric, but we're happy to share some of that. We have a train the trainer. And basically, this is what we will be offering a variant of across the pediatric pandemic network through this Responder Resilience Learning Collaborative that we're launching. Next. And this is what it looks like. It's a personal resilience plan. Next. The metaphor, the enemy are expected stressors, and one of those potentially is rapid evacuation. And how do you combat that? It's through being prepared for it, having a personal resilience, and then being able to really specifically call out specific active coping tools and strategies you'll use. Next. Next. We'll just zip through these here. This is kind of what the model is like. Hopefully some of you will be interested in joining us. Next. It uses a self-triage that does not require any identifier to look at some risk factors related to their medical role in dealing with kids, the impact of whatever the disaster is on their own families, because sometimes the evacuation is something that also portends risk for their own families. And what's their own level of risk Are they exposed to danger? Do they have access to PPE? That was a, big issue, in COVID. It could be something else in a different disaster type. And we have a published study on this. We have another one with CDC. It's not quite published, but basically we're able to predict prospectively out subsyndromal PTSD without using symptoms, just looking at exposure related to their role in disaster in the hospital. Next. And we have the strategy. I won't take you through all the nitty gritty, but basically one size doesn't fit all. And this is basically driven at the level of the individual responder needs or individual provider needs. Next. We did have a large healthcare system that used it during COVID. They used the self-report system. It was voluntary among all their staff. Again, it aggregated, but without any individual identifiers. And they basically used it from April of 2020 through December of 2020. It took a couple of months break, but then they restarted it with concern about COVID worsening in the fall. And they looked at different units within their hospital. So this is an even more sophisticated approach. It was not just the ED, it was NICU, MICU, different wards where some of the COVID patients were, and they looked at all of these factors. So they took this from our system. Next. And we have evidence that suggests what the individual predictive algorithm is. And they looked at and they applied those algorithms to the database. You can basically see, in the 40s, consistent with the literature and the literature that's emerged since then. Next. And then they took that to the C-suite. They converted that data into hopefully more pertinent information for action strategies by the C-suite in that hospital. So data out of our system got packaged this way by their wellness lead. Next. And we found that it led to, and this is from the Ebola so-called Monrovia Medical Unit. This was over an extended course of providing care in a very challenging care environment. They were in medical tents. It was just providing care for Ebola. They weren't treating other medical conditions. So it wasn't really a field hospital. It was just an Ebola treatment unit, ETU. And you can see a lot of resilience. So it's a very mixed, a lot of green. They had a lot of behavioral health assets. They had this system in place. And we saw very, and the Surgeon General and the Deputy Surgeon General modeled use of the system, actually, and we saw a lot of buy-in. And we were able to see the impact over a sustained event. Next. So if you're interested in this, and we're excited that it's been funded by the system itself has been adapted based on some a pilot project by a PEM physician here at Harbor UCLA, Tabitha Chang. She was funded by PPN to modify our tool to do research to see, gee, if it's those that are primarily taking care of kids, what changes do we need to make to this? Will it still predict? What changes to the training curricula, the anticipate, plan, deter? And so she just completed those results, and we have built the beta version of the self-triage system or self-monitoring system that was just built on the last day of the project year, and we'll be using that together with a modified training based on her results in this new PPN Learning Collaborative that will get underway. We think the intro sessions again will be in December. So if you're interested in being added to the mailing list to learn more about that, email me, and we'll send that out as soon as we have something scheduled. That's it for me. Happy to take any questions or dodge rotten tomatoes. Oh, we know the treatments are effective. I'm sorry. Yeah, this is, I would like people to look at this also. This is, yeah, what David's posting is not the learning collaborative that I'm talking about, that's something different, very interesting on evacuation. This is the Action Collaborative on Clinician Wellbeing and Resilience from the National Academy of Medicine. They have a lot of resources. It is not focused on PTSD, so ours is a different focus, a gap that we've identified. But I would definitely encourage folks to have a look at this. All you have to do is Google Action Collaborative on clinician well-being, and you'll get to that. Next. They have this whole change maker model to get hospitals and folks to engage. So consider becoming a change maker at your own facility. Next. Okay. There was something from AHA, but that's fine. There is something from the American Hospital Association also on clinician mental health impacts. So that's another thing to have a look at.
Thank you, Chip. So we're going to do breakout sessions. Think about the things that you've heard from the team from CHOP, and think about the things that you've heard from Dr. Schreiber. Great presentations. We learned about how to incorporate the behavioral health, but also thinking about how do we protect that staff, and how do we incorporate the behavioral health into that our evacuation plans. So we're going to do a few breakout sessions, and the specific questions I want you to think about is in what ways have your hospital's behavioral mental health professionals been involved in disaster events? So whether that's in the pre-planning stages, in the drills and the exercises, or actually within the events themselves. We also heard from your TTX surveys that we've obtained so far that the biggest gap that everybody is having, and that's evacuation, surge, reunification, and TICD across this focus area sessions, is that staff training is a big gap. So a question to you is, what staff training do you feel your hospital needs for successful pediatric evacuation? So we can start to think about that for the rest of the collaborative over the next 6 to 7 months. So I know several of you need to hop off, and that is totally fine. So we're going to have 2 breakout sessions. I'm going to go ahead and create those and put you all in there, and we'll come back right at 10 minutes. So about 38 after. Okay, so no one came back early, which means to me that there were a lot of great conversations. So I apologize for pulling y'all out. Hopefully we can continue this conversation. But anybody from room 1, that is Austin, Brian, Cassie, Leisha, Pat, Shannon, Stephanie, anybody from room 1 would like to report about any ahas or share anything you want with room 2? I can't come off mute. There. You should be able to unmute yourself now
There
if
we
someone from
go.
room 1 wants to.
Well, we had some very nice shares in our room with our group. They talked about the various types of individuals and different types of providers that are actually in their facilities to help with, debriefs and also mental health support, and raise the issues of the chaplains. And more than one individual in the group shared that the chaplains and the mental health professionals were very very interested in becoming involved in disaster preparedness and playing a role, even though they didn't seem to really know what their role should be. They need a place at the table. And then we were talking about the self-care issues associated with disasters. And Kathy, can you unmute? Because I think the instances you shared were just really powerful.
Oh, I was saying that before 2012, when I got to Charleston, there were 3 events that clearly had traumatized staff that I heard about. And as I'm listening to all this, I wish somehow I could have captured data from it. But one was evacuating pediatric psych patients during Hurricane Floyd, and they were doing it in kind of like passenger vans, and they got stuck on the highway for much longer than they thought, and they ran out of meds, and not a good situation. And then another one was setting up an employee daycare during a hurricane response. And they said it was chaotic and the kids were upset. And one lady was like, I will never do it again. If they make me do that, I will quit. And then the third one was evacuating a patient floor because of a fire. And I did actually reach out to that charge nurse, and she was just basically saying the feeling of utter or lack of preparation. That was it. And she had told them she was going to quit, and she did. So she had left healthcare because of that.
Yeah, and I think it just brings home the toll of the stresses and the burden that Dr. Schreiber was talking about, in terms of it's just one more thing on top of everything else that just kind of I mean, disaster is a big straw. It's probably a big log that breaks people, and they can never go back. Certainly in our RAPID group, and I think Annette remembers this during the triple-demic. It's even hard for me to remember it, but the stories of turning down patients who needed to be transferred and subsequently died, because they couldn't be transferred. There was no place else to go, and the desperation of the emergency people around that.
Room 2.
I know time is short, so I'll throw in a couple of bullet points, but Pat, you got me like that whole voice crack thing, because I know exactly what you're talking about. And we can't afford to lose any more providers, especially the ones that aren't gonna leave anyway. So in our room, we decided that there was a paucity of addressing behavioral and mental health, and including them in evacuation and disaster planning, and a desire to put them more at the forefront versus a last minute addition to things. And then the exciting thing for me to hear is about staff training and what folks felt like they needed, and there was just a suggestion of concrete strategies to bring staff in and include them, and then also for the making of resources specifically pre-incident, so that staff could be more resilient, more ready, which again addresses both Pat's point and Chip's point about, if we know, we can begin to prepare, but if we don't know what we don't know, then we can't even go there with our minds. So, but yeah, we had a fantastic discussion in our group. Thanks, everybody.
Thank you very much. Great. Last few slides, just letting you know that the DRC upcoming sessions, we will meet here the same time, same place, 1 month from now on October 7th. It'll be the same Zoom link that you used to get in today. And then for November is our full collaborative session. And I put that link in the chat, and as well as this QR code. Here's the code for the continuing education units. LEKSUH. Also put that in the chat for you. And these slides will be available later this week, early next week. And then here's that wonderful session evaluation. Let us know what you thought about today's session. Any feedback is good. We've hopefully you've noticed that we have used the feedback that we've gotten. We're making sure that we get those breakout sessions in. We try to hold it longer, but we just have wonderful speakers and these questions that come about during that, and so it's good times for everything. So we are definitely keeping time for your breakout sessions because we've gotten good feedback on that though. So any feedback is very helpful, and we use that. So please fill that out. Once you have that pulled up, you can go ahead and log off because that is separate. It won't cut off when the session cuts off. And everybody can have a wonderful day. I hope it is sunny and good weather where you are. Thank you all for joining us.